So at 11:50 we have a symposium on aortic regurgitation with sponsored by Jena, which is a very important, interesting device to be known.
So thank you, Francesco. We're going to move directly to this, taking the next step in the evolution of aortic regurgitation treatment. And I invite the speakers to join the podium here. Well, in fact, treatment of aortic regurgitation, percutaneous treatment, is really evolving. We do have new information, we have ongoing trials, and a lot of expectation. So with this in mind, we have this great symposium sponsored by Jena Valve. I would like to thank Jena for helping us in the meeting and sponsoring this symposium. So we will start with a case presentation or a Trilogy case. And Becky, please.
Okay, I get a little more time than the prior lecture, so I'm going to present a case that we've done at Columbia. And just to put you in the mood, this is just a little description of the Jena valve. So how many, or the Trilogy valve, how many know about the Trilogy valve from Jena? Okay, so this is a little bit new for many people, but this is the valve has commissural alignment, is able to be oriented to center itself within the commissures. And then it has these locators that you can see here, the three locators for the three different sinuses. And that allows them to be positioned correctly, but also to prevent too deep an implantation. And then there's dual anchoring and sealing, the flared skirt, which conforms to the annulus. And then, of course, the leaflets are actually being clipped by the locators and clipped against the valve. So there's actually two different sealing mechanisms, which are the leaflets themselves. So any device that's grabbing the leaflets is going to actually use the leaflets as a mechanism to reduce paravalvular regurgitation. And then it also has a skirt. But the other beautiful thing is it's because it's capturing the leaflets, the risk of coronary occlusion by the leaflets is pretty low. But if in younger patients, if we're going to need to reaccess the coronaries, there are very, very large open cells. And because the device is perfectly aligned every time, the large open orifice is right over the coronaries. So this is a kind of a beautiful design of a valve. The inclusion criteria for the single-arm trial that was just completed, the Align-AR trial, was the patients had to be symptomatic. They had to have greater than or equal to 3+ AR based on a multiparametric approach. They had to have a anatomic suitability by CT scan, as all these valves do, and they had to be high risk for surgical intervention. And the assessment of aortic regurgitation was based on the usual, and I think will be covered later by Madalena, but was based on the usual multiparametric approach that you see here. This is the publication in the Lancet by Torsten Wahl, and his co-PI was Vino Turani. The valve was CE marked in 2021, but is not FDA approved yet. And so the 1-year primary endpoint in this single-arm trial, the valve was able to meet its primary safety endpoint at 30 days, as you can see here, with a rate of 26.7, where the pre-specified non-inferiority margin was 40.5%. The main safety issue was the pacemaker rate, which was relatively high at 30 days, but was found to be directly related to the implantation depth. And then as the trial went on, the implantation depth became higher, and therefore the pacemaker rates became much, much lower. So toward the 14, 15% rate that many of the other valves have. And then the primary efficacy endpoint at 1 year also met, and this has resulted in not only improvements in regurgitation, basically no regurgitation, and but also then LV remodeling and improvements in quality of life. And so these are the results from that from the paper showing again New York Heart Association functional class marked improvement, and some of the highest KCCQ overall score improvements that we've seen in trials. There's a 22-point increase in these patients, with also a similar marked increase in the 6-minute walk distance, which has tended to be rather difficult in many of the other trials that we've seen, but you can see here tremendous improvement, significant improvement in the 6-minute walk distance that tended to occur at 6 months, but continued to get better over the course of the year. Now, the hemodynamic valve performance is unusually large because, again, these patients have aortic regurgitation and not aortic stenosis, so they don't have a lot of inherent calcification of the leaflets, and therefore the valve areas end up being very, very large. That's not really going to be an issue for this valve. But of course, the paravalvular leak rate exceedingly low, given the two different mechanisms of sealing. The 2-year outcomes was just reported in TCT in October, again showing what the initial study, the 1-year results showed, which is continued left ventricular remodeling, both in size and LV mass. You can see here that just a progressive reduction in LV mass, a very consistent and sustained hemodynamic valve performance, and that includes not only valve area but paravalvular leak, and then of course a consistent and sustained improvement in New York Heart Association class and functional and quality of life metrics. So this is the case that I'll present is a 66-year-old male, lots of comorbidities, including prior CABG and therefore open heart surgery. He obviously has other issues as well and presented with New York Heart Association Class 3 symptoms. The echo findings I'll show you in a minute, but clearly showed really very, very significant aortic regurgitation. His CT analysis showed adequate sizing for a Jena valve, 23 millimeter, and no other contraindications, which include the length of the aorta of less than 55 millimeters. Here you see that the straight length of the aorta is totally fine, and the annular sizes, again, would dictate that we would put in a 23 millimeter Trilogy valve. And so that's indeed what we had decided to do. The access, the vascular access was adequate for this valve. And when we got in there, and this was, the TEE had been done, but perhaps not quite interpreted the same way that I ended up interpreting it intraprocedurally. But I called the investigator to say that this patient has intramural hematoma. So do you all see the issue here with the aorta? So you can see that there's a marked thickening here and separation of the intima from the adventitia. This is the media, and that is when you look in the short axis view, you can see this crescent-shaped thickening there of the media, and that is bleeding into the medial layer of the aorta. This is an intramural hematoma, and the intramural hematoma ended up extending down into the sinus of Valsalva, causing malcoaptation of all 3 leaflets, and in doing so then created this tremendous amount of regurgitation that you see here that we quantified really as, I mean, we don't have a torrential scale, but I mean, this would really be a torrential aortic regurgitation, secondary to malcoaptation of basically all the leaflets, but primarily 2 of the leaflets. So then the question became do we need to abandon this particular procedure? And so we elected to then use Echo Navigator. So this is echo fluoral fusion, because as you can see, with using 3-dimensional echo, we are able to identify the actual cusps and the level of the sinus of Valsalva, because in this particular case, the locators now cannot touch the sinuses. Now, normally we're okay with it being relatively low and touching the sinuses. In this case, we need it to be a millimeter above the sinuses in order to not create an aortic dissection. And so echofluorofusion was used to identify the sinuses of Valsalva. We introduced the sheath. This device has tremendous rotational capabilities that can move it off the aortic wall to prevent any interaction with the aorta itself, which was integral for this particular case. We then very, very slowly advanced to the sinuses while watching on echo and fluoro the entire time, again, using echofluorofusion. Now you can see the locators here, 1, 2, and 3, and the device is able to be rotated. So then the final position, we were able to center the locators within the sinuses and then also ensure that we had restriction of the leaflets and therefore had captured the leaflets with the locators. And that would allow us to have some security that we were going to capture the valve well and have no paravalvular regurgitation. So this is the final check by fluoro and echo just prior to our pacing run and deployment of the valve that you can see on the bottom right-hand corner. And so as the valve comes out, you see again that the locators were not allowed to touch the sinus, the bottom of the sinuses of Valsalva. This is the final result. This is just a little bit of wire regurgitation. The final result showed no regurgitation, completely beautiful valve. We assessed the aorta throughout its entire length with no change at all in the intramural hematoma. The peak and mean gradients were 11 and 5 with a valve area of 2.03 for this small patient and small annular size. This is very good and without any prosthesis patient mismatch. So the current guidelines clearly suggest that surgery is indeed the procedure of choice in the setting of severe symptomatic aortic regurgitation. But now with the Trilogy valve being able to treat these patients, is it time to change the guidelines? And so the new ARTIST trial is now a randomized trial for surgery versus Trilogy and is now ongoing and enrolling. Thanks for your attention.
Thank you, Becky. I think we're going to have the 3 presentations in a row and then later discussion. Please don't forget that if you have any questions and you don't want to take the mic, then you can send the QR code. Madalena, let us move to your presentation. Why we are not properly diagnosing and treating aortic regurgitation patients.
Right. So why are we not diagnosing correctly aortic regurgitation? First of all, the diagnosis of aortic regurgitation severity needs specific image optimization. Reason why we have later on a workshop about that. So you can see this is the same patient, the same time, seconds apart, the 2 images. On the left side, you have correct image optimization demonstrating a holodiastolic flow reversal in the descending aorta. And on the right side, you have usual standard image settings on an echo machines, and you can miss the holodiastolic flow reversal in the descending aorta. Now, the evidence needs to be obtained from well-informed study designs. As you can see on this slide from this study, I'm going to go like this because I was tempted to show you that actually this recently published study is still including very young population and a very low percent of female patients. And there is good evidence that actually the younger the patient, the more the dilatation of the left ventricle, and male patients dilate the ventricles more than women, which means that by including this population in a study where you try to demonstrate better ways of assessing aortic regurgitation, you definitely end up with the conclusion that the aortic regurgitation severity is correlates with the dilatation of the left ventricle, but it only correlates in the population you chose for your study. Furthermore, this tendency of moving towards MRI for assessment of aortic regurgitation has to be questioned, because as you can see from this study, which again was trying to bring MRI into the discussion, actually MRI underestimates in a significant percent of patients the severity of aortic regurgitation as diagnosed by echo, despite what I was already telling you, that on echo we're very poor at diagnosing aortic regurgitation severity because we haven't focused on it. The same like we used to be very poor at assessing tricuspid regurgitation till Becky Hahn has turned on the lights on the tricuspid valve, and now we're all better at it. Furthermore, this vena contracta that we are asked to measure and was used in this study for assessing the aortic regurgitation severity on a parasternal long axis view is very dependent on settings of the machine, including the 2D gain. So with a higher 2D gain, giving more priority to the tissue, so to the gain than to the color, you will obtain a lower vena contracta. Furthermore, this is not a circular orifice, so the vena contracta that you obtain on a parasternal long axis view is not necessarily the vena contracta that represents the true severity of the valve. The same like used to happen with tricuspid regurgitation, and then we understood the morphology of the jet and how important it is to look at the vena contracta area rather than at the vena contracta, or to measure the 2D vena contracta in different projections. Okay, so I'm gonna move on from here now. So regarding the regurgitant, the dimensions of the left ventricle, the dilatation of the left ventricle in aortic regurgitation, which is hemodynamically significant, I will not call it severe or non-severe, but hemodynamically significant for the respective patient, the dilatation is a form of adaptation. Is meant to stop the pressure, the diastolic pressure from going up, and consequently the atrial pressure from going up and the patient becoming breathless. But this ability to adapt to aortic regurgitation is lost with age. So this is a beautiful study which is more and more used to demonstrate this loss of ability to adapt to aortic regurgitation with age, which means that we need to consider better individuals which are older in age as maybe having severe aortic regurgitation with a smaller regurgitant volume. And there is more and more evidence in this regard. You can see this beautiful study from Cleveland Clinic, which actually found that there is less left ventricular enlargement with age in aortic regurgitation, which was in need of intervention, in need of surgery, and there is less left ventricular enlargement in women than in men. And actually, we can think about it as having two distinct phenotypes of aortic regurgitation depending on the age of the patient. The young individual, usually with bicuspid aortic valve or with a cusp prolapse, which developed aortic regurgitation from a young age and throughout decades, more severe, will have a very enlarged left ventricle, the classical type of aortic regurgitation phenotype, which was of interest in the times when only young individuals were sent for surgery because the risk of surgery was very high. And the second phenotype, which is the older individual that developed aortic regurgitation at an older age when the ventricle was already small fibrotic HFpEF type with low flow, which we know is more and more common as we advance in age. And these individuals will find it hard to dilate their left ventricle. So there will be severe aortic regurgitation with normal left ventricle size or small left ventricle. We also, from this study, we also understand that we need to have distinct left ventricular thresholds for women and for men. We need new thresholds and we need distinct thresholds for women and for men. Already there is evidence that 38% of individuals requiring aortic valve replacement have non-severe aortic regurgitation based on current classification of aortic regurgitation severity. And it is found in this study that lower cutoffs are needed both for regurgitant fraction and for regurgitant volumes. And probably because this study also included a higher percent of women and an older population in it. There is also more and more evidence, progressive evidence, I call it, showing that we need to move earlier with an intervention in aortic regurgitation because there are adverse outcomes when the ejection fraction drops below 60%. So all the evidence and consequently all the guidelines were recommending waiting till ejection fraction was dropping below 50%. Subsequently, American guidelines and NICE guidelines moved to a threshold of 55% based on evidence which was considered good enough to inform guidelines. And now there is evidence that even ejection fraction less than 60% should trigger an intervention on the valve. And it's also the global longitudinal strain. Global longitudinal strain was found to be associated with outcomes as an absolute value, but also drop at follow-up. So in your valve clinic, if you follow up patients with aortic regurgitation, it's good to do global longitudinal strain serial. Even if you have some doubts about global longitudinal strains in between machines, use the same machine for the same patient and then do the follow-up of that patient. And dropping global longitudinal strain at follow-up is associated with guidelines. And even more, the study actually included moderate to severe rather than severe aortic regurgitation. So moved thresholds of severity down into looking for worsening outcomes in these patients if they are treated based on current guidelines of intervention. My last thing to say is that echocardiography needs to move beyond basics because we can on echocardiography perform at follow-up assessment similar with the assessment done eventually on CT to size the valve to see whether the patient is within the category that could benefit from a transcatheter valve. And this is because the transcatheter valve we are talking about, you've seen before the case presented by Dr. Han, is available only in 3 sizes. So it's good to know at follow-up whether your patient falls into the category that matches one of the sizes. And I'm not saying that you don't need to do a CT subsequently for sizing, but it's good information for you to decide on timing of intervention, whether or not the patient could have a transcatheter intervention. Now, in conclusion, we need new thresholds for severe aortic regurgitation. We need better assessment of aortic regurgitation severity by improving our skills of image optimization specific for aortic regurgitation. We need new left ventricular thresholds. We need to define the 2 distinct AR phenotypes, and we need to treat patients earlier. Thank you.
Thank you, Magdalena. So we will move before the discussion to the last lecture. Victoria, she will address what is next in the evolution of aortic regurgitation treatment.
So thank you very much for the invitation. And I think that we all agree from the sessions of this morning and now in this session that we need a much better characterization of our patients and move beyond the cutoff values and rather much more understanding how the patient presents and which are the other characteristics. So I will hammer a little bit of what has been said so far, but going into the guidelines that probably will change this year. I don't know, we will need to see, but is what we are claiming for. So what matters in aortic regurgitation decision-making? First of all, in the management, according to the schema that the guidelines of 2021 provide, is whether there is significant enlargement of ascending aorta, and that is because another animal. But we can translate that sentence into which is the mechanism of aortic regurgitation, because the mechanism of aortic regurgitation is going to be one of the determinants on how we are going to treat that patient. Is a type 1. Type 1 means that there is a dilatation of the aortic root at different levels, and you can subdivide according to which level is the dilatation happening. Type 2 will be when there is a prolapse of one of the leaflets of the aortic valve. And type 3 is much more the degenerative one, when there is also a restrictive motion. So it's very often that they coincide with aortic stenosis. After we have done this assessment, where probably echocardiography is going to be the first approach to evaluate that, and we need to move towards three-dimensional techniques in order to properly assess the movement and the dimensions of a kind of crown-like structure, and then a cylindrical one. No way that we can do it with only 2D echo. We need to move to whether there is severe aortic regurgitation or not. And we have seen the difficulties in assessing the aortic regurgitation. This is an example of a patient with a bicuspid aortic valve. We can get discontinuous wave Doppler. No way that we can get a good alignment with the regurgitant flow. But also, even if we get an alignment with the aortic regurgitant flow, the pressure half-time can be misleading in some situations. Probably going much more into 3D echocardiography and trying to measure the vena contracta area will help us much more to redefine that severity. And it has been also said the magnetic resonance. Magnetic resonance has several ways of assessing this aortic regurgitation. We can do the phase contrast, we can do the 4D flow, and perhaps the value that we are getting and that Madalena was pointing out in that graph, it may be different than the PISA that we have in our mind and that we have been working on. So we need to understand what measurement each technique is giving us. PISA, or the vena contracta area, is at 1 point, a 1 second, millisecond, or whatever you want to call it, of the cardiac cycle. And the CMR is giving you that flow throughout the entire diastole. So maybe the cutoff value should be different. Maybe we are interpreting different numbers. So we need to sit down and try to reconcile those data. Then we have the symptoms, whether the patient is symptomatic or not, and many times these patients are asymptomatic. Exercise test can help us to unmask symptoms. Exercise echocardiography, for example, in our center, we do it quite much, and it's also useful to see how the ventricle behaves. But then we need to check the left ventricle. And what we use in clinical practice and what the guidelines recommend is, again, ejection fraction, despite the limitations, and the cutoff value used is 50%, and the end systolic diameter of 50 millimeters. And if you do it corrected by body surface area, is 25. We have more and more data showing that actually those cutoff values are quite conservative, and we should be perhaps more aggressive and trying to reduce or to put a higher ejection fraction, such as 60%, or a much smaller end systolic diameter. And this slide has also been shown where you can go beyond ejection fraction and diameters and going much more into the mechanics with global longitudinal strain, and whether there are one abnormality or if there are more abnormalities. Now, this is what we see perhaps in clinical practice. 61-year-old patient, no coronary artery disease. He has some symptoms of NIA class 2, ejection fraction of 57%, end systolic diameter 42, and diastolic diameter of 66, a severe aortic regurgitation. The patient, because has symptoms, goes for aortic valve replacement, and after aortic valve replacement, where is my ejection fraction? This is what we don't want to see. And if the patient later on evolves towards heart failure, we start to put medication. Of course, perhaps you say it's too early. We need to give more time to that ventricle to remodel back, to gain a little bit of the contractility. But who has the crystal ball to say whether that patient will recover that or not? That's the difficulty that we see. And I think that having now new therapies that can be less invasive for the ventricle even, can help us to understand better how will be the response of the ventricle to that relief of the pressure and volume overload that aortic regurgitation has. We have already the trial from the ALIGN AR and even the 2-year outcome of the ALIGN AR. And we have even data coming from off-label TAVI versus the specific device designed for aortic regurgitation. This is a meta-analysis of the dedicated versus the off-label transcatheter aortic valve replacement for native aortic valve regurgitation. And you can see that those that are dedicated for aortic valve regurgitation have much better outcomes in terms of all-cause mortality, less residual aortic regurgitation, transcatheter valve embolization, reintervention, or pacemaker. So the data are there coming. What I want to know in the future is, for example, how these valves behave in terms of the ventricle. This is the Journey J-valve pivotal trial that will include as well the cardiac magnetic resonance, and we will have at 1 year follow-up the CMR with a volumetric assessment to assess the LV remodeling after the intervention. So the goals of this trial will be exploring the volumetric and the myocardial differences between genders and determine if earlier intervention for aortic regurgitation translates to improved ventricular remodeling, and understand the impact of LV remodeling on clinical outcomes and quality of life. But this will be kind of a single arm. What I'm much more interested in having the comparison with surgical aortic valve replacement. And here is where the ARTIST trial will show in terms of randomizing patients to transcatheter aortic valve replacement versus surgical aortic valve replacement. That will give us the next step for building the guidelines and the recommendations whether the patients are better suited for surgery or for transcatheter. But eventually for me, in my clinical practice, I don't want to see another patient with an ejection fraction that is gone. I also want to know how each treatment will impact in each for the ventricles. And that is one of the trials that will help me to understand as well that even though the primary non-inferiority endpoint at 12 months is death, any symptomatic stroke, and urgent cardiac hospitalizations, I'm sure that there will be data coming from the left ventricle. And as you have heard during the entire morning, we need to go earlier to those patients in order to preserve the structure of the heart. So TAVI for aortic stenosis has changed the management. I think that TAVI will change or may change the treatment of the paradigm of aortic regurgitation. We need to characterize the aortic regurgitation mechanism in order to decide which is the best therapy for each patient and the patient is suitable for transcatheter aortic valve replacement or not. We need to understand the response to the aortic valve replacement in terms of recovery of the left ventricular myocardium. Is this the same with surgery versus transcatheter? And then, of course, for patients, if we are going to go earlier, we need to understand durability of prosthesis, need for pacemaker, and other situations that we may face in order to make sure the patient doesn't develop heart failure. And with this, I would like to thank you for your attention.
Thank you. So great presentations. We do have almost 20 minutes for discussion, which is great. And I would like to start with a question coming from the audience. And I think that, Madalena, I think you need to answer that. So the new released BSE guidelines state a normal LV size almost always rule severe aortic regurgitation. But is this completely ignorant to gender and age difference?
Yeah, it's very ignorant, in my opinion. As I showed, and there is more evidence that I didn't put up because the talk was supposed to be within 6 minutes. However, there is very good evidence, and particularly the study from Cleveland Clinic that I did show is a large number of patients, over 800 patients, followed up for about 10 years, and at the moment when they needed surgery, their left ventricles. So there is really very good evidence that dilatation of the left ventricle, it's only specific to the phenotype of the young patient with aortic regurgitation.
Becky,
the only other thing is, we're talking about chronic, aortic regurgitation, so not acute. So we're talking about over a long period of time.
Becky, any comment related to the incidence of pacemaker in this new treatment?
Yeah. So the pacemaker rates were, so the locators, in the beginning, we were positioning the locators right on top of the sinuses, and that ended up meaning that we had a relatively low implant because the skirt and the bottom of the valve comes out below the locators. And then over time, we were moving the locators up so that it's just like when in the initial TAVR valves for aortic stenosis, we know that for the self-expanding valve, if you move it up and you implant only within 4 millimeters of the annulus, you're going to have less pacemakers, and that's exactly what happened with the Jena valve, with the Trilogy valve, and so we do think that the pacemaker rates really are going to be similar to any of the other TAVR valves that are out there.
Victoria, one question for you. Well, in the guidelines, and still the decision making is mainly based in diameters, but is this? Why are we doing that?
That's a good question, knowing that the imaging modalities have helped us have evolved in order to have 3D volumes or much more accurate dimensions. But we need to understand what we are doing now, what will be the future. Look at the past. The guidelines were based on registries, particularly on aortic regurgitation, on the tool that we had available in order to characterize those patients. We have now more data that may change that, but you need to make sure that also a large proportion, a large group of clinicians are going to be treating patients safely. And so far, these measures have worked. Are not perfect, but have worked. And you don't miss patients that are going to develop, for example, heart failure. Now, do we need to go earlier? Particularly when we have now techniques, either surgical or transcatheter, that are less invasive, that lead to a much faster recovery of the patients. I think so that we can go earlier. It's just now to recalibrate those cutoff values. But again, this will be a discussion always with the patient in the center, because you need to understand who your team is. You need to have good surgical results, good transcatheter results, good imagers understanding the concept. You cannot have an earlier intervention and then perhaps, because of low volume, capitalize or jeopardize the outcome of the patient. So this needs to be integrated within the team.
Yeah, the only other thing that I wanted to add about the current guidelines that use, for instance, a diameter of and systolic diameter of 25 millimeters per meter squared, is that we have so many studies now suggesting that cutoff should be 20. It should be much lower. And I literally face-to-face asked Catherine Otto why she didn't change the guidelines. And, she always answers back, well, there aren't any trials. And that it's very hard to do a randomized trial of intervening, just based on 20 millimeters versus 25 millimeters. So, I'm hoping that the new guidelines are being generated now for the US, that they'll take into account the voluminous data that is now showing that the cutoffs should be much, much lower.
Let us be practical. So seems that we need to treat early, but what is the best method to decide when to treat? We're going to treat earlier.
I think we don't have one only method. It will be an integrative approach. However, it's easy when the patient is symptomatic, because I think the biggest cause of delay is that the patient is symptomatic, but is elderly with a small left ventricle, and the breathlessness is blamed to other causes. So the aortic regurgitation is ignored, and the patient is not sent for an intervention if they're old. And on the other hand, in the younger individual, we have a lot to lose because there are decades in front of them. So if you have severe aortic regurgitation when you're in your 30s, 40s, 50s, and you delay till the ventricle is very big and very weak, you may never recover systolic function like Victoria showed. And you may recover size and develop diastolic dysfunction, and you may be breathless for the rest of your life. So I think an integrative approach should consider global longitudinal strain, should consider MRI for volumes and ejection fraction, which is better than echo, and can also look at myocardial fibrosis. and should also consider exercising younger patients which may not be symptomatic.
I was just going to, we've discussed exercise stress testing before because there are no great, the guidelines are relatively vague about the cutoffs that we need to use for calling it an abnormal stress in aortic regurgitation. And I think that that's an area that we need to really investigate. We've got to have better, more strict cutoffs by which to decide these patients are actually, have severe disease, not just.
Yeah, I have a large number of patients which are really, really extremely young, in their 20s, with bicuspid aortic valves and AR or combined AR and AS. And what we do now is we do CPET combined with exercise echo on the upright bike. And we can get global longitudinal strain at rest and at low workload, ejection fraction on 3D at rest and on low workload to look for contractile reserve, and also the CPET results. And it is the one or the other which will actually push me into referring the patient sometimes, because sometimes it's the CPET, it's not the exercise echo. And the patient, it's the CPET result which is abnormal. And it's a very well validated and very good way of assessing the asymptomatic individual with severe aortic regurgitation.
Perfect.
Please. Yeah. I just want to comment this wonderful lecture of Madalena that she pointedly very, I think, important issue with what we have now. We have now two different group of the patients. It's a young patient with a long-lasting regurgitant lesion, but as well we have old patients with the same regurgitant lesion, but for them, these lesions mean something else because we have a different ventricle coping with such a lesion. So we come now back to pathophysiology that not only systolic function we are facing with, it's diastolic as well. And this diastolic dysfunction in the old population made completely different environment in which this actually regurgitant fraction is coming on, and what does this mean for the patient and for our estimation of the severity of the lesion. So I think this is this might be somehow bring into the guidelines that these are two different group of the valvular patients. And as well, regarding the ejection fraction, I think we were trapped with the ejection fraction because in the regurgitant lesion, ejection fraction may so lower. We are just, I think, confused about this. Anything that is less than normal should be suspicious that something is going on with the ventricle, because as what we know what ejection fraction is, that if we have increase in the volume, it means we should have supranormal ejection fraction if the ventricle is normal. So I think this is some points to be considered when we are talking about what is the severity of what we should do with the particular patient. Again, back that the patient has to be in the center and integrated approach.
So practically, this is the paradoxical low-flow aortic regurgitation.
Right.
Yeah. So we have many questions here. Let us try to get short answers. Can you tell us, maybe Victoria, if there are any cutoff for AR during exercise echo? Is a PA pressure, ELS, drop EF, or only symptoms?
I think that one of the parameters that was measured was the contractility and the response, whether the ventricle could cope with the exercise in terms of also the pressure that you are going to generate. Aortic regurgitation is a double load, pressure and volume overload. So when you do exercise, the pressure may increase even more, and if the ventricle cannot cope with that, that is a sign that the ventricle is damaged and you should refer for treatment.
Becky, when deciding dilatation of the LV, will you trust more biplane echo, 3D echo, MR?
Wow, such a good question. Obviously, the guidelines are asking that we do the linear dimension, as we've already complained about. But it's also that where we do the linear dimension makes a difference. And so, we've been taught to do it probably a little bit too basal than what has been shown to correlate best with MRI. So it should probably be just after the bulge. So I still rely on that, but in truth, it is about the volume. And so I think that volume by any measure, whether it's 3D volumes or CMR, perhaps, I don't like to use the word gold standard for CMR, but I mean, it is considered for chamber volumes to be extremely good and reproducible. And so I would say that, either one of those more volumetric assessments may in the end be what we use to characterize these ventricles a little bit better. And we have some cutoffs from CMR. The Journey trial that was mentioned is using CMR in order to, not miss patients where echocardiographically we're having difficulty quantifying, and it's going to use the CMR cutoffs for volumes.
Madalena, what GLS is abnormal in severe aortic regurgitation?
So there is the paper I showed, both me and Victoria, considers poor outcomes are related with a GLS lower than -15. However, a GLS -18, lower than -18 was also found to be related with worse outcome in aortic regurgitation. And contractile reserve, that Victoria said, was also measured through increasing GLS at low workload. So it's not just increasing ejection fraction at low workload, which defines contractile reserve, but also more specifically, more easy to measure in more patients, increasing global longitudinal strain to
Becky,
by 20%.
Becky, this is coming back to you. Seems you need to convince more the attendees. So we know that 2D, 3D, echo, and MR are given different volumes and different ejection fraction. Which one you rely on to send a patient for intervention?
Wow, they're really nailing me on this one. So the thing about ejection fraction, we're not going to talk about straightforward volumes, but the thing about ejection fraction is that when you all modalities seem the correlation of ejection fraction is very, very good, and that's probably because you're correcting for your error in calculating LV diastolic stroke volume and systolic stroke volume, so that when you actually do the calculation for ejection fraction, the modalities are highly correlative. And so if you're talking just about ejection fraction, then I would say you could use almost anything, including nuclear. But if you're talking about volumes, then it again, depending on the expertise of the site, because even the AI-generated volumes on a 3D echo requires typically some manual correction. And so in order to get closer to the CMR values, but in good labs that have use it all the time, like Denise's lab, the error is as small as 10 cc's. So it's not something around there. So it's not the error between those two methods is not very high.
Thank you. So we still have a few minutes, Victoria. This is a difficult question. If we consider the old aortic regurgitation phenotype, so low flow, less dilatation, could the BCI 3D be better than regurgitant volume?
Thank you for this very interesting question. I mean, I like very much the 3D vena contracta area for me. And it's reproducible, and I think that is less load dependent. But maybe Madalena has a different opinion about that.
I don't know how to answer this question, because actually it will be again a combination, and I think probably regurgitant fraction will be better. Regurgitant fraction because you need a smaller regurgitant volume to have severe or significant aortic regurgitation if you have a smaller ventricle. So I would vote for regurgitant fraction.
Becky?
Yeah, so I mean, similar to what Madalena says, I think it's going to end up being multi-parametric. We also like 3D VCA. We integrate it over the diastolic time interval So every single frame we trace and divide by the number of frames. And I think that gets to it. We're also doing quantitative Doppler using our RV outflow tract stroke volume, but you could do it also using three-dimensional echo and getting the total LV volume versus and subtract maybe the RV volume. And that should also get you regurgitant volume. And I think we're learning about which ones are best. But we like those two methods best of all. PISA is very, very difficult, I think. And then as far as regurgitant fraction, I don't disagree at all that regurgitant fraction may be what's important for that patient and that ventricle. But I think our cutoffs are too high.
I'm very happy with the attendees because they don't let you escape. So they're coming back to you, Becky and Victoria. Well, tell me suggestions how to improve reproducibility of the BCA 3D.
Do a lot. Acquire the data, practice, do it yourself, do someone else doing it also. And I think that learning the multiplanar reformation planes, how to use them on 3D, is very useful. It's hard sometimes to learn, but you will get it. And I think that there are plenty of workshops here that will teach you about that. And you can go back and master it at home. I think that being a contractor area with the multiplanar reformation planes is very useful.
Yeah, I agree. It just takes a lot of practice. We practice every day and on mild, moderate, and severe disease to get a feel for how accurate. But because we're also doing those multiple other methods, we're correlating it with what we see on other methods and therefore getting very comfortable. But it's very, very good, particularly if you're using TEE. The transthoracics, because the aortic valve is a little bit more far field, may not be quite as accurate, I think.
So last 50 seconds, one question, Madalena. In the presence of moderate MR, what is the effect on parameters in echo for severe AR?
So I think that more importantly is what's the effect on the left ventricle. So, and first of all, what type of MR? So if you have moderate MR in a patient with AR, just the first thing we need to think about is that that AR might be severe, might have dilated the left ventricle, and the MR may be a sign of decompensation, maybe secondary MR. The leaflets no longer touch because the ventricle is dilated because of the AR significance. So I would think that moderate MR should be seen in this regard more than just seeing about the aortic regurgitation, in the sense of more volume overload and what will happen with pressure half time, because we don't use that for assessment of severity anyway. We mainly use parameters related to the valve orifice and to the regurgitant volume.
Perfect.
Just a last comment. Remember that if we're relying on regurgitant fraction, that in the setting of MR, that regurgitant fraction now is very low in the setting of possibly severe AI. So just be very careful when you're using these parameters to understand their limitations in the setting of concomitant disease.
So I think it was an excellent session. Thank you all the speakers. And I think that don't forget that it's a complex problem. So we need to be precise in diagnosing. It's not only the valve. We need to treat earlier, and we have the ongoing trials with 1,000 patients that we will just try to see what happens against surgery. Thank you for your interest.